Up next is Dr. Neena Ravindran, and since the time is really scarce, please, Madam Ravindran, switch on your microphone and you can talk.
Yes, sir.
Good morning.
Good morning, sir. Good morning, everybody. Myself, Dr. Neena Ravindran. I'm going to present the bird view perspective of Ayurvedic treatment principle for diabetic retinopathy under the guidance of Dr. Ashwini BN and Dr. Keshiva Balaji from Amrita School of Ayurveda from the Department of Shalakya-Tantra, Kollam, Kerala, India. The contents of my, is it moving? The slides are not moving, sir. Hello? Whether the slides are moving, sir?
We have the first slide, the bird view perspective.
Yeah, I'm trying to move the next slide, but it is not moving. That's why I'm asking.
Not yet. But if you can continue with what you see and maybe...
Yeah. So these are my contents of the presentation. So coming to the diabetes. Diabetes is a systemic and metabolic disorder, and diabetic retinopathy, it refers to the retinal changes happening to a diabetic patient. So it usually occurs to a patient who have diabetes after the onset of diabetes from 8 to 10 years. The patient will be having diabetic retinopathy, whether the diabetes is controlled or not. Coming to the prevalence of diabetic retinopathy is about 4 to 28%, and 2% of the diabetic population is blind as a result of diabetic retinopathy. So coming to the pathogenesis, in hyperglycemia condition, there will be increased retinal blood flow. So there will be disruption of metabolism in endothelial cells and pericytes. So there will be impaired vascular autoregulation. So increased vasoactive substance production and endothelial cell proliferation will be there. So that in capillaries, there will be reduced lumen as well as hypoperfusion. So there will be chronic retinal ischemia will be presenting. So that there will be increased production of vascular endothelial growth factors. Thereby the endothelial cell growth will be forming to new cell vessel formation, and because of increased vascular permeability, there will be retinal leakage and exudation. Now, coming to the risk factors, one of the most risk factor is the duration of diabetes, because roughly around 50% of the patient affect diabetic retinopathy after the onset of diabetes after 10 years, and 70% of people will affect after 20 years, and 90% will affect after 30 years. And the next thing is that the age of onset of diabetes, and the next thing is poor metabolic control, next thing is hereditary, and pregnancy. Pregnancy actually accelerate the condition of diabetic retinopathy. Then hypertension. If it is associated with hypertension, it can highlight the changes in diabetic retinopathy. And the other factors like smoking, obesity, anemia, and hyperlipidemia are the risk factors. Actually, this diabetic retinopathy is having 4 stages. The first one is non-proliferative diabetic retinopathy. The second one is proliferative diabetic retinopathy. The third one is diabetic maculopathy. And the fourth one is advanced diabetic eye disease. So coming to the non-proliferative diabetic retinopathy, increased vascular permeability and occlusion are the 2 main observations in retinal vasculature seen in case of NPDR. And the ophthalmoscopic features we seen in NPDR are microaneurysm, retinal hemorrhage, retinal edema, dark blood hemorrhages, hard exudates, cotton blood spots, and some venous abnormalities also. So this is the case of mild NPDR. We can see a hemorrhage there. And next, in case of moderate level of NPDR, we can see microaneurysm, hard X-rays, flame-shaped hemorrhages. And in severe NPDR, we can see venous bleeding apart from the other 2. And the next is proliferative diabetic retinopathy. It is that it comes to in every cases after 25 years of the onset of the disease, and it is especially characterized by the neovascularization of one or more of the following features, like neovascularization of iris or ankle or at the epididymis or elsewhere in the retina. And these new vessels may proliferate in the plane of retina, and it may spread to vitreous as some vascular folds and major atlases result in fibrovascular retinal membrane and causes vitreous detachment and following the vitreous hemorrhage. This we can see neovascularization of the retina. Next, coming to the diabetic maculopathy. Diabetic maculopathy is when the macula sustains from some more form of the damage. In case of diabetic macular edema, where the blood vessels near the macula leak fluid into in between the layers of the macula can be seen. The next case is advanced diabetic eye disease. It is the end stage of uncontrolled PDR, and it is highly marked complication. We can see some complications like vitreous hemorrhage, retinal detachment, and neovascular glaucoma. And usually the management comes like a screening. First we need to give a fundus examination. So in 5 years after the diagnosis of type 1 diabetes mellitus and at the diagnosis of type 2 diabetes mellitus, and in every year there is no, it has to be examined or it has to be screened till there is no diabetic retinopathy or there is mild NPDR. And in case of moderate NPDR, we need to do fundus examination in every 6 months, and in severe NPDR we need to do fundus examination in every 3 months, and in every 2 months in case of no high risk characteristics. And investigation, obviously, like in every disease, we need routine examination like a blood routine examination, urine examination. Apart from that, HbA1c, FFA, and OCT plays a key role. FFA, it helps to analyze the extent of neovascularization, leakage, and capillary non-perfusion. And in OCT, especially in diabetic maculopathy, it gives a structural study regarding the retina. Now, coming to the treatment modalities adopted it is intravitreal vitreal and anti-VEGF drugs, intravitreal steroids, laser therapy, and if all the above 3 are failed, they will go for surgical treatment. Now, coming to the Ayurvedic perspective, Acharya Vagbhada explains 27 Drishtigata Rogas and Acharya Shushruta explains 12 Drishtigata Rogas, and among that one is Parimlaya Timida. So diabetic retinopathy can be understood in terms of Parimlaya Timida because of the Pitta Rakta Visheshan, and the severity of the condition depends upon the quality of Ahara Prasada Rasa, because what the food we are consuming, and thus the Ahara Rasa Doshana Vished Pitta Dosha, and thus aggravate the symptoms. Similarly, in case of diabetic retinopathy, the blood sugar level depends on the patient's diet, and the symptoms and signs increase or worsens depends upon the patient's glycemic control. So this is the pathogenesis according to Ayurveda. If somebody is having unwholesome diet and regimen, there will be impairment in digestive fire. So there will be ama formation, and the srotas, that is the channels, will be getting blocked. So if it is blocked, it will be known as Sangha. So blockage of microcapillaries, hyperfluorescence in the FFA can be seen. If there is Sida Grandhi, that is in term, it can be correlated in terms of aneurysm and neovascularization, and Bimargam, it can be seen like hemorrhages and exudates. And if ama is formed, all the doshas along with rakta is got vitiated, and it will cause vitiation in netra patalas, that is the layers of retina. So it will hamper the visual acuity, and thereby the disease will be progressed. So coming to the treatment protocol, we can categorize it into 2 steps. So in first step, we need to do Shodana because the channels are getting impurities. So it has to be purgated, or we should remove some impurities in the Shrotas. And the Shodana can be done in 2 forms, like Shida Shrododushti and Netra Shrododushti. So in Shida Shrododushti, some Tala Podichal, Takradara, Shirodara with Kasha, all these procedures can be done. And for Netra Shrododushti, some specialized eye treatments are explained in Ayurveda, like a Netra Kriya Kalpa. So Avaguntanam, Anjanam, Ashrodhanam, Netra Kiri, Kabalam, Bidalagam, all this can be done. So some sort of inflammation is also there. So Shopahara line of treatment should be adopted in such cases. Netra Shopahara Chikitsa in terms of Seka, Avagodana, Vidalaga can be done along with internal medicines for anti-inflammatory medicines can be given along with alanoma medicines. So the next step number 2, we need to make the eye more strengthened because inflammation and Shrododushti has cured. So we need to make the eyes more balya. So Chakshusha medicine should be given. So Netra Belle Chigilsa like Tarpana, Murdane like Shiro Abhinga, Shiro Pichu, Shiro Basti, Shiro Dhara had to be advocated. So these are some of the medicine suggestions like internal medicines like Vasha Gulicha, the Kashayam, Gulicha, the Kashayam and all, Anjana like Chandanadi Anjana. All these are the beautiful formulations we can be used in diabetic retinopathy conditions. And thalapodichil, these are the suggestions for medicine we can be used for thalapodichil, Shirodhara, and Tarpana. And these are the procedures. The first one is Seika, the second one is Ashtotana, the third one is Vidalaga procedure, and the fourth one is Anjana, fifth one is Tarpana procedure. This is the picture of thalapodichil, and this one is Shirodhara. And so now I'm concluding my presentation that a regular screening of diabetic population should be done to reduce the prevalence and incidence of blindness within the population. So in Ayurveda, diabetic retinopathy can be approached in the principle of Parimala Timra. Initially, Shodha Shodhana, followed by Shobhara, incorporating Pitta Shamaka and Rakta Prasadana, and then Brahmana line of management for the restoration of the health of the retina. So I am concluding my presentation. Thank you.
Okay, thanks Dr. Neena Ravindran for her presentation.